Hello, and welcome to a breakthrough research presentation on the cost-effectiveness analysis for integrated social and behavior change programming by the Resilience in the Sahel Enhanced 2 program in the Maradi and Zinder regions of Niger. In this presentation, we will briefly review the background and methodology and then get into the results and discussion. First, some background information. This work is funded under Breakthrough Research, which is USAID's flagship social and behavior change project for USAID's Global Health Bureau to drive the generation, packaging, and use of innovative SBC research to inform programming. This particular study is part of the broader SBC costing and cost-effectiveness portfolio that has been developed under Breakthrough Research. The Resilience in the Sahel Enhanced 2, or RISE 2 initiative, is funded by USAID and is a multi-sectoral program that addresses several priority health behaviors, including those in the maternal, newborn, and child health area, such as antenatal care and facility-based births, family planning, nutrition outcomes such as breastfeeding, and wash outcomes like hand washing. RISE 2 is implemented by multiple partners, including 3 different Resilience Food Security Assistance Organizations, or RFSAs. Breakthrough Research designed an evaluation study of RISE 2 using population survey data that provides the foundation for this analysis. Because integrated SBC has the potential to generate efficiencies in SBC planning and can leverage the connections between different health outcomes, it is hypothesized that integrated SBC would be a cost-effective intervention. However, this has largely been untested. So we decided to explore this question by examining the cost-effectiveness of SBC investments in RISE 2. Due to time constraints, we examined cost-effectiveness at the time of the Breakthrough Research Midline Survey, which was 1 year after the baseline survey. Since we recognized this was a relatively short time frame to assess cost-effectiveness, we also explored what level of increase in health outcomes would be necessary to yield cost-effective results by the end of RISE 2 SBC programming activities in 2025. Our overall approach for this study was to first start with the Breakthrough Research Impact Evaluation of RISE 2 and calculate the additional costs and impact associated with the integrated SBC program compared to control areas. To estimate cost effectiveness, we needed to calculate an incremental cost effectiveness ratio, or ICER, which is a measure of the additional costs divided by a measure of additional impact. Starting with impact, we use the available behavioral health outcomes measured at the baseline and midline surveys and entered them into the Lives Saved tool, or LIST, which can estimate the number of maternal and child lives saved due to the improvements in health behaviors. Because the time frame between baseline and midline in this study was only 1 year, we also wanted to explore what the potential longer-term program cost effectiveness would be if key health outcomes improved by 25% by the end of the scheduled RISE 2 program in 2025. For this, we had one scenario where we used the available outcomes and then included a second scenario where we added a 25% increase in breastfeeding outcomes, although these data were not available at baseline but are an important health outcome to consider. For each scenario, we converted the number of lives saved estimated due to the RISE 2 SBC activities into disability adjusted life years averted, or DALYs, using the Global Burden of Disease tool data for Niger. A DALY represents a year of healthy life lost due to death or disability. So when we estimate the cost per DALY averted, we are estimating what the cost is to prevent the loss of a healthy year of life. In calculating costs, we started by collecting the SBC expenditures of the program at 2 points in time. First, we collected the SBC expenditures from all partners from program initiation in 2018 through September 2021, and we completed an initial report on the breakdown of those costs into different cost categories. We next collected SBC expenditure data from October 2021 through September 2022. When we calculated the total costs up through midline, we annualized the early program design expenditures over the life of the project to 2025. We also added in any additional service delivery costs associated with increased health services utilization due to program activities by using the default values in the list costing module. With the impacts and costs estimated, we could then calculate the ICER and examine cost effectiveness. We calculated the cost per DALY averted, as shown here, and then compared that to the GDP per capita of Niger based on the cost effectiveness thresholds established by the World Health Organization, where a cost per DALY averted that is less than 3 times the GDP per capita is considered cost effective, and less than 1 times the GDP per capita is considered highly cost effective. For Niger, we adjusted the most recently available GDP per capita to $2022 for a threshold of $1,896 US to be considered cost effective and $632 to be considered highly cost effective. Here, you can see the results from the impact evaluation at midline. During this time period, there were drops in the proportion of women who reported at least 4 antenatal care visits in both the intervention and control areas, but this was more pronounced in the control areas. At the same time, there were statistically significant drops in having at least 1 antenatal care visit in the control areas, but not in the intervention area. Another variable with statistically significant changes was the percent of women living with a hand washing facility that had both soap and water. When we model these numbers in LIST and look at the net difference between the intervention and control areas, we see 4 additional lives saved by the intervention, which translates to an estimated 122 DALYs averted. Here, there are substantially higher impacts seen in our 2 hypothetical scenarios that consider a 25% increase in the health outcomes from baseline through 2025 compared to the midline analysis. For our first hypothetical scenario that is limited to the health outcomes available in the Breakthrough Research Baseline Survey, we see an estimated 4,835 potential DALYs averted. When we include breastfeeding outcomes in our next scenario, we see a substantial increase to 12,131 potential DALYs averted by 2025. In terms of costs, you can see here the calculated SBC expenditures based on the expenditure data and the additional service delivery costs due to SBC from the list costing module. In total, there are $5.7 million of costs estimated at midline, and this increases to $19.9 million by 2025, assuming that SBC expenditures continue at the current pace. You can see that there are no differences between the 25 improvement scenario, which does not include the breastfeeding outcomes, and the 25% plus breastfeeding scenario, because breastfeeding is already a part of the RISE-2 program, and so the costs were adequately captured, but the outcomes were not captured at baseline. No additional service delivery costs are expected due to a rise in breastfeeding outcomes. When we calculate the ICERs, we see that the cost per DALY averted for the midline and 25% investment scenario is above the $1,896 threshold for cost effectiveness. However, the third scenario that adds in the hypothetical increases in breastfeeding outcomes by 2025 is cost effective. We would like to highlight 3 key findings from this report. The first is that at midline, the SBC investments do not appear to be cost-effective based on the calculated ICER. This is not surprising, however, as there was only 1 year between the baseline and midline surveys, and this may not have allowed adequate time to observe substantial changes in the health outcomes. Additionally, the impact of COVID-19 and other environmental disruptions also likely influence the outcomes. Our second finding is that when taking a longer view, the cost effectiveness of the RISE 2 SBC investments is potentially achievable. Note that a 25% improvement in 5 years would be a notable increase, but not beyond what is feasible for most health outcomes. For example, if 10% of the population had proper hand washing facilities at baseline, a 25% improvement would translate to 12.5% of the population with proper hand washing facilities in 5 years. A third key result really emphasizes the importance of capturing all the relevant outcomes into the impact measure. Although we were unable to include breastfeeding outcomes in our midline analysis due to data limitations, when we added it to the hypothetical 25% improvement scenario, it made a big difference, and it was the determining factor between cost-effective and not cost-effective investments. This highlights the importance of capturing all the impact that SBC generates into your common denominator, which can be challenging as not all outcomes can easily map to a common impact. It is important to consider these challenges when conducting SBC cost-effectiveness analyses, particularly for multi-sectoral programming like RISE 2. There are several limitations to note. First is the brief time frame from baseline to midline, which also includes the onset of the COVID-19 pandemic. Second, there was a challenge of mapping the outcomes to a common impact denominator. Not all outcomes that are a part of SBC interventions are included in LIST. For example, reducing early marriage, which is a part of RISE 2 programming, but not of LIST. And not all outcomes translate into DALYs. For example, a multi-sectoral program that included education would not translate into DALYs. Additionally, all models have limitations in that they rely on assumptions. On the cost side, different assumptions were made to allocate SBC expenditures over time. On the impact side, some of the outcomes did not show statistically significant changes from baseline to endline, but were included for this exercise. Despite these limitations, this is one of the first studies to examine the cost effectiveness of integrated SBC, and there are some important lessons gleaned. First, while a 1-year time frame is premature for yielding useful cost effectiveness results, the hypothetical scenarios included in this analysis indicate that if substantial gains could be made in key health outcomes, cost effectiveness could be achieved by project end, although these scenarios are, of course, speculative. Looking forward, more research is needed to examine the cost effectiveness of integrated SBC and further exploration on what types of integrated programming are most cost effective. For more details about this analysis, scan the QR code to access the full-length report, as well as other research on SBC costing and cost effectiveness. Thank you.